Hello, you're welcome to my platform. I am Dr. Sandra and I am a surgeon. I hope you become aware and sensitized about the different surgical conditions. Today's video is about erysipelas. Erysipelas is the inflammation, that is the irritation of the superficial part of the dermis, as well as the superficial lymphatic vessels. By the way, the dermis is the second layer of the skin, and it is divided into the deep part and the superficial part. It is the superficial part where erysipelas affects. You have also heard me talk about the superficial lymphatic vessels. The superficial lymphatic vessels are a collection of tubes that drain lymph from between the cells of the dermis, and they take this lymph into the veins such that the veins can take it back to the heart together with the blood. Lymph, by the way, is just fluid that collects between the cells, and it is as a result of leakage of fluid from the blood vessels, and this fluid can accumulate between the cells. In erysipelas, these superficial lymphatic vessels are also affected. The commonly implicated bacteria in erysipelas are the streptococci, specifically the group A streptococci, that is Streptococcus pyogenes, and the non-group A streptococci. The bacteria can enter the skin via an injury. It can be a road traffic accident, a tattoo, a piercing. It can be any skin condition, for example, psoriasis, eczema. The bacteria can also reach the skin via blood, and this can be as a result of an infection elsewhere in the body. For example, in the respiratory system, in the context of pharyngitis, the bacteria can be carried by blood to reach the skin, and it can cause erysipelas. The individuals that are commonly affected by erysipelas include individuals that have lymphedema. Lymphedema is simply swelling as a result of collection of fluid between the cells. This fluid is called lymph in this context, and this lymph is as a result of some fluid leaking from the blood vessels, and it can settle between the cells. This fluid usually collects because the lymphatic vessels could have been blocked, and they cannot extract this fluid from in between the cells back into the blood, such that it is taken to the heart via the veins. Individuals that have a wound on the skin for some reason, it can be after a surgery, it can be a road traffic accident, a tattoo, a piercing, an ulcer for some reason, maybe venous insufficiency. Individuals that have lymphatic obstruction, for example, they could have had filariasis, that is a parasite that blocks the tubes that are supposed to extract fluid from between the cells. Or the lymphatic vessels, those tubes that are supposed to extract fluid from between the cells, could have become injured, or the patient could have received radiotherapy and they got injury to the lymphatic vessels or the entire lymphatic system. Individuals with arteriovenous fistula, that is an abnormal connection between the artery and the vein. Individuals that have recurrent respiratory tract infections, for example pharyngitis, as well as individuals that have a low immunity for some reason. For example, they have HIV, they are on steroids, they are on anti-rejection drugs. For example, they have undergone an organ transplantation. The commonly affected sites include the upper and the lower limbs, that is in 80% of the cases, as well as the face. When it comes to the signs and symptoms of erysipelas, the affected individuals will develop some presentations 48 hours before the skin presentations occur. For example, they will develop chills, fevers, muscle pains, joint pains, headaches, and nausea. And after that, after the 48 hours, the skin presentations will occur. The skin presentations of erysipelas usually start as a small reddened patch. It can then progress as a bright red patch with clearly demarcated raised borders. This patch on the skin is usually indurated. That is, when you touch it, it is hard and it is tense and shiny. Before we can move forward, there is something I really want to emphasize about erysipelas. Erysipelas is usually misdiagnosed as cellulitis, and I think you can bear witness that you have not seen so many patients that have been diagnosed with erysipelas. This is because it presents as cellulitis, and it is really important that we get to know how to differentiate between erysipelas and cellulitis. It is all about the margins of the lesion that is formed on the skin. The lesion of erysipelas is usually well demarcated, while the one of cellulitis is ill demarcated. You cannot easily make an outline that this is where the condition ends and this is where the normal skin ends. But in erysipelas, we can always have a demarcation between the normal skin and the affected skin. So whenever you get a patient, please look at the line of demarcation. The line of demarcation between the normal skin and the inflamed skin, the irritated skin. Because in erysipelas, we always have that clear line of demarcation and the borders of the lesion are raised, creating that nice demarcation between the normal skin and the affected skin, which does not happen in cellulitis. In severe cases of erysipelas, there can also be bullae, vesicles, as well as petechiae and necrosis of the flanks. By the way, bullae and vesicles are just small swellings that contain clear fluid that might develop on the surface of the lesion of erysipelas, while petechiae are small spots that are red and sometimes purple that might occur in these lesions. The diagnosis of erysipelas is purely clinical. We only do history taking and clinical examination. We don't have to do any laboratory tests in order to diagnose the patients with erysipelas or to start treatment. When it comes to the treatment of erysipelas, we can employ supportive management and definitive management. In supportive management, we can employ elevation of the affected area. For example, if it is the leg that is affected, the leg can be elevated. We can also employ non-steroidal anti-inflammatory drugs, the NSAIDs. For example, ibuprofen, aspirin. We can also employ cold compressions, resting of the affected area, as well as encouragement of oral rehydration. The definitive management of erysipelas involves the use of antibiotics, and we usually use the penicillins as the first line of management. For example, we can employ dicloxacillin, flucloxacillin, cloxacillin, or we can use the first generation cephalosporins, for example, cephalexin, especially in patients that have allergic reactions to the penicillins. And we use these medications for at least 5 days. The take-home message is erysipelas can easily be misdiagnosed for cellulitis. It is no wonder that we rarely see this diagnosis made in the hospital setting, yet there are so many patients that are assigned the diagnosis of cellulitis. And I have a feeling that some of these patients that are assigned the diagnosis of cellulitis are actually patients with erysipelas. Although the management strategy is the same, it is really important that we get to know how to differentiate between erysipelas and cellulitis, such that we can assign the right diagnosis to the right patients. To repeat, in erysipelas, there is usually a clear line of demarcation between the normal skin and the affected skin, because the border that separates the normal skin and the affected skin is raised. So you can easily tell that this is where the normal skin starts and this is where the affected skin ends, which does not happen in cellulitis. That clear line of demarcation is absent. You cannot easily tell that this is where the normal skin starts and this is where the affected skin ends. Because that clear line of demarcation is absent, it is a little bit ill-defined in cellulitis. I hope to see the diagnosis of erysipelas made more in our hospital settings. I hope there won't be any more bunching of the two conditions together, because majority of the time erysipelas is misdiagnosed for cellulitis. I hope that the difference has been clarified and that the patients will be assigned the right diagnosis. That is what I had for you. Thank you so much for listening to me. Please share my videos and also subscribe. See you in my next video. Bye.